My name is Nigel Davies, and I'm a consultant ophthalmologist at Guy's and St Thomas's Hospital. And I'm very grateful to have been asked to give this presentation at the Macular Society conference. The title of the presentation is New Treatments for Wet Macular Degeneration. So we have about 20 or 25 minutes just to go through some information, and I hope that you find it useful and understandable. So just by way of introduction, I think I'm just going to talk about the eye as a whole, introducing it in similarity to a camera, and then describe the specialized area of the macula. And then I'm going to just tell you a little bit about age-related macular degeneration, the problems that arise inside the eye that lead to it, and the problem that lead to the problems with the vision. And then describe the new treatments, the existing treatments for wet macular degeneration before moving on to the new treatments for wet AMD. And then finally, some concluding remarks. So we have a sort of nice story starting off with the eye, then a bit of understanding about the macula, then age-related macular degeneration, the current treatments for wet AMD, and also then the new treatments for wet AMD. So I said, well, I'm going to describe the eye as a camera, but actually, I probably really ought to say that a camera is rather like an eye, because with the eye, which you can see over here on the right-hand side of the panel, we have had millennia and millennia of development of the human eye, and we have beautiful optical equipment at the front of the eye, and that's mirrored on the side on the right by the lenses in a camera and the iris mechanism that we all use in our cameras. At the back of these systems, there's a detector. In the eye, there's the nerve layer, which is called the retina. And in the camera, well, there used to be a photographic film, but now there's an electronic sensor. So these two things are very similar. In cross-section, the eye looks rather like this. This is a schematic diagram. At the front, we have the optics that we were just looking at. And then there's a big cavity of gel, which is called the vitreous. And then the layer on the back is the retina. And right in the center is a specialized area. Now, on this slide, that's marked as the fovea, and I'll describe what that is in a moment, because that is part of the central retina. Here is a photograph of the back of an eye. You can see over on this side, there's the optic nerve head, and that takes all the visual information into the brain. It also brings the blood vessels in. It's a conduit for arterial blood to come in the eye, and you can see that runs along these little vessels, and it takes the venous blood out as well. So that's a very important circulation device as well as being the optic nerve. But in the center, there's a spot, and the Latin word for spot is macula, and that's a spot in the back of the eye. This panel on the right shows you the macula in a little bit more detail, and what you can see, there is a sort of reddish spot in the center with a bit of slightly darker color, and the blood vessels there tail away, and there are no blood vessels in the very center. This is a super specialized area for our detailed vision. The other investigation that we use now all of the time in ophthalmology is called an OCT scan, which is optical coherence tomography, and this gives a 3D slice through the macula and through the little specialized bit in the center, the fovea. And you can see this is a scan of my macula, and this is the layer of the retina. So in this picture, the front of the eye is right at the top with all the focusing equipment there. Then you've got the gel cavity, and then it comes round like that. And this is just a very small centralized area in the back of the eye. Now, this is a static picture, but what you can see is down at the bottom here are blood vessels. Then there's some bright bands of reflection, and then a big paler one just up here. This represents the light receptors, which are the important bits that are doing the seeing. And here is the blood supply. And underneath is this very, very important layer called the pigment epithelium. I'm going to be concentrating on that layer because that is the origin of age-related macular degeneration. If we zoom in a little bit, just on the center, it's a bit grainy because of the resolution of the picture, but here is my fovea, and here is the pigment layer. Now, these cells are the most active cells in the whole body. They need an awful lot of nutrient, and they need a lot of looking after. And that is the role of this layer underneath, the pigment epithelium. We have a big blood supply underneath, and the pigment epithelium has taking nutrient from the blood, delivering that to the light receptors as they need it. the light receptors every day produce a lot of waste products. So the retinal pigment epithelium takes those waste products, dissolves them, and puts them back into the bloodstream. And it also has a recycling mechanism as well. So important chemicals and nutrients are recycled in and out of the photoreceptors. So this layer is critically important in the health of the retina. Now, the only thing I haven't done is really tell you about how big this area is. The distance between the pit of the fovea from one side to the other is really about 0.5 millimetre, and the very middle about 1/3 of a millimetre. Now that's the size of the rollerball on the tip of my pen, which you can't even see on the video there, but there it is. You look at a pen, it's the size of the rollerball. So all of us, for the whole of our lives, will be relying on two of these little areas separated by about 70 millimetres, and some people will only have one eye from an early age. So they have just one little area that's about 0.5 millimetre in diameter that gives all of the detailed seeing. So this is a really, really important part of the body, because if you have a problem with this bit, it affects one's vision, that affects your ability to do things, that affects the whole family and society around you. So this is a critically important part, not only of the person, but also of our society as well. I think that's an interesting way to think of it. The reason why it's so important, of course, is if this part suffers, then the vision is affected very badly. If you have a problem that's away to the side, doesn't really affect the eyesight very much. So this is the critical bit. So the problem with age-related macular degeneration, as I've already said, starts off in the retinal pigment epithelium. We look over here to the left of the picture, and all of those layers are nice and smooth. What happens over time is sometimes those retinal pigment epithelial cells just don't work properly, and they don't deal with the waste products properly. So the waste products pile up underneath, and you can see there are bumps there. And these bumps, when we look at the eye with our examining equipment, look like little yellow dots, and also they can become like crystals. So they get the German word drusen, which is a word meaning crystal. So you will hear the word drusen in the macula to these collections of waste products that are sitting just underneath the retinal pigment epithelial cells. So then what happens is this: these pigment epithelial cells are separated away from their blood supply. They get lifted up by this blister of debris. And when you have cells that are away from their blood supply, again, they don't work terribly well, and the light receptors over and above also don't work terribly well. But one of two things will happen over time. This is with the same patient, but the other eye. And I'll show you, this is the patient's left eye. And again, you can see now the little bumps, which are collections of waste products or drusen sitting underneath the very center of the retina. Now, with this problem called dry macular degeneration, these cells are separated away from their blood supply, and over a period of time, they slowly die away. When they die away, the deposit just dissolves and disappears, but unfortunately, the light receptors over the top also disappear, and that has that big effect on the quality of that person's vision. Now, this picture was taken in 2018, and I saw this patient again during the course of this year. And unfortunately, the central vision in this eye had been badly damaged by dry macular degeneration. And I'll show you the next slide, which is the picture from this year. And you can see that all those bumpy deposits have disappeared, the light receptors have disappeared, and you have a patch here in the middle where those critical components of the visual system are missing. Off to the side, both to the left and the right, you have more normal looking cells. So this is the problem of dry macular degeneration, and it is something that at the moment we are powerless to treat. So what happens with wet macular degeneration? Well, it's a different type of response. In wet macular degeneration, the cells that are lifted away from their blood supply signal for help. They release chemicals that stimulate the growth of new blood vessels from the blood vessel layer underneath. So you can look out on the right, there's a great big blister here where the pigment epithelial cells are lifted away from their normal position. And these ones have survived and signaled for help. So the eye has grown into this space, a whole cluster of new little blood vessels. Now that sounds like it would be fantastically beneficial, and in some situations it is, but actually most of the time, these new blood vessels actually cause more problems than they ever solve, because they release even more fluid. They're very leaky, and that causes the retina to swell up, And if you look on the top, you can see these circular spaces there, which are the retina full of extra fluid. And on this other eye, again, cells are not separated from very far from their blood supply. New blood vessels have grown into this area. There's a whole load of fluid being released and the whole thing gets stretched up. So the back of the eye, it gets all boggy and swollen up with extra fluid. So we call it wet age-related macular degeneration. So this is a rescue process where the eye is trying to heal itself, but it just doesn't really work very well. And ultimately, these vessels undergo a scarring process. They can break and bleed, and that has a devastating effect on the central vision. So this patient came one day with blurry vision for a period of a few weeks, unable to read, with distortion in their central vision. I'm going to show you another patient now just to illustrate the blood vessel growth. This is another patient, again, who came with distortion of vision. Here is the retinal pigment epithelium. It's elevated up a little bit, and there's some murky fluid there, which is causing the vision to be affected. And this is the OCT scan. There's another type of OCT, which is called OCT angiography, that shows the presence of the blood vessels. Here is the patient's scan on the left-hand panel, but this one is looking down on the back of the eye, and the scanning device has been able to extract information about blood flow. And what you can see here is a thing that looks like a sort of flattened tree. There's a great big set of branches of blood vessels there, and little smaller blood vessels at the edge of that. And this is the abnormal blood vessel network that has grown underneath this patient's retina, and that is releasing the fluid, and that is the underlying problem that is damaging the vision. A clear distinction between dry age-related macular degeneration, where the cells die away slowly over a period of years, and wet macular degeneration, where you have the growth of blood vessels, which are trying to help the situation, but actually they don't, they just make it worse. Now, the understanding of wet macular degeneration is such that we know that the group of biochemicals that cause the problem are called the vascular endothelial growth factors, or VEGF for short. And once that was understood, then antibodies were developed, which can be injected into the eye, and these are known as the anti-VEGF agents. So patients with wet macular degeneration and also many other retinal diseases can now have these injections of anti-VEGF agents, and they are astonishingly effective. The current treatments, we have one which is called Avastin. Now, that's not licensed for use in wet AMD, and it's not standard treatment in the UK. It is used in some situations, but it hasn't been used wholesale. There are some studies that have been done which show that it is equally effective to Lucentis, so it's a good use, but it remains unlicensed and always will do. Ranibizumab, or Lucentis, was licensed for use in 2008. Aflibercept, which the drug name is the trade name is Eylea, that was licensed in 2013, and brolucizumab, or Beovu, was licensed in 2021. So we now have 3 licensed agents for the use in wet macular degeneration and 1 unlicensed one. Just go back to our patient who appeared a couple of years ago in our clinic, and this is the day the patient came. You can see now the retina all swollen up, and that is clearly wet macular degeneration in both eyes, and the patient had a remarkably reduced vision. The patient had 1 injection of ranibizumab into each eye and came back a month later, and I'll just show you the difference in the scan. Just take a mental picture of the swelling that's there. Look at this. This is 1 month later. All of that fluid swelling has gone away, apart from a little bit in the middle, and the sticky fluid that was there, and some of that elevation of those cells has disappeared, but a very dramatic change on the right, with all of the fluid going away and that great big blister disappearing almost completely. It's quite an unusual response. It doesn't always happen like that, but this is a fantastically good structural response to that single treatment. We carry on the course of treatment once every 4 weeks, and the patient already knew that the vision was very much better. So these are, when the person responds to them, fantastically successful treatments. So the quick review so far is that the macula is a specialized area for vision. Degeneration starts with collections of waste products. You either get this problem of atrophy, where the cells die away, and that is dry macular degeneration, or you get the signaling for help, which is wet macular degeneration. And in the UK, the current treatments are ranibizumab. Licensed treatments are ranibizumab, aflibercept, and brolucizumab. So now we get to the new treatments. The new injection treatments, the one we're very excited about is faricimab, and I'll tell you about that in a short while, and then ones that are called biosimilars. There are also a couple of depot treatments under development, one called a port delivery system, and another which is a polymer added to a Lucentis type molecule for. So faricimab, or its other name Vabysmo, its license actually was approved earlier this year. So we do already have this one almost available. It was very effective in the clinical trials, and it was fast-tracked through NICE, the National Institute for Clinical Excellence, through that appraisal process. And actually it was recommended for use in wet age-related macular degeneration and diabetic macular edema on the 29th of June this year. So it's absolutely brand new. My hospital actually has ordered its first batch, and that will be arriving next week. So we're excited about its use. It has two major actions. It is an anti-VEGF agent, so it blocks the effect of the vascular endothelial growth factors, also blocks the effect of another set of chemicals called angiopoietin-2, which are also important in the growth of the new blood vessels. So it's a dual action treatment. So why are we so excited about it? Well, you start off with 4 treatments, once a month for 4 months, you haven't given. And after that, as long as the eye has responded well, you extend that to 8 weeks for one visit, then to 12 weeks for another visit, and then up to 16 weeks, which is 4 months. Now that in itself is interesting because you extend the treatment by 4 weeks at a time, whereas with ranibizumab and aflibercept, when you start the extension period, as long as the eye is stable, you have to add only 2 weeks at a time, so people end up with more treatment. In terms of the visual outcome, the eyesight tests were the same as the standard treatment with aflibercept on this 8, 12, and 16-week regime. But the reason why we're so excited about that is that nearly half, 45% of people, only needed treatment every 4 months. That means they only needed 3 visits to the eye hospital for injection every year. And actually 3/4 of people needed treatment only every 3 months, so 4 visits a year. So this is a fabulously good thing for the individual because it interrupts their life much less than the current treatments do, and it will also allow us in the hospital eye service to have more appointments available for more patients. So we're very excited about faricimab. That is the newest treatment, and it's already just becoming available. The biosimilars are developed after patents expire, and the aim of a biosimilar is to be a similar molecule which aims for the same outcome as the one that you're mimicking. They're less expensive, and the idea of that is that allows it to be available to a larger number of people and then reduce the disease burden overall for a nation. It doesn't necessarily aim to get a better outcome for the individual. So there are ranibizumab biosimilars. There's one called Razumab, which is approved in India, and there are a couple of other ones which are under development. This one, Samsung Bioepsis, I thought it might be a new type of mobile phone from Samsung, but no, it's not. It's a biosimilar for ranibizumab. Here's a patient again with wet macular edema. You can see how well it responds to the treatment with aflibercept. Aflibercept biosimilar, aflibercept's patent expires in 2023. So some are in development. They still have their code names rather than their actual drug names, but again, those will probably be marketed at some point in 2025 or something like that as biosimilar treatments. There was a treatment called apixabar which was being developed, but that caused a lot of inflammation in patients, and that hasn't been approved, so that one we don't think we're going to get access to anymore. Another one called OPT302 has a wider action on the vascular endothelial growth factors, and Convacept binds more strongly to the vascular endothelial growth factors, and that's been approved for use in China. This one I think is very interesting, KSI-301. It's an anti-VEGF agent like ranibizumab bound onto a polymer. So when that's put into the eye, it stays there for much longer, for a period of several months, and that one is actually quite promising, I think. The other system I want to talk about is the port delivery system. Now, this is a very interesting concept. This is to use ranibizumab, so our well-known agent, but with a small surgical procedure on the patient's eye, which is used as a sort of depot deposit. You can see on the picture, the schematic picture here, there's a little reservoir which is put inside that gel cavity, and that's filled up with ranibizumab, which slowly oozes out over time and gives continuous control of the disease, and then can be refilled as needed. And the study that was done had 3 initial concentrations of ranibizumab at 10, 40 and 100 milligrams per milliliter. So think of that as, a small amount, a lot. And when patients needed refills, the small amount at 8 months, so that's a very good time away from the hospital, the middle amount at 13 months, and the larger amount at 15 months. So imagine that, coming to the hospital just only once every 15 months to have this little refilled. That would be quite stunning. Now, this study that was done recently had about 250 group, and the port delivery system group had refills every 6 months as been, and almost everybody didn't need any additional treatment in the first 6 months. So it looks like this actually does provide a nice slow release system within the eye that would keep people out of the hospital and keep their vision good for a long time. The port delivery system has then potential to be very good, but there are some complications that were associated with the device. It's a foreign body in the eye, so about 1.5% of people developed an infection. Some got bleeding inside the eye, about 1 in 20, and some had surface problems, again, about 1 in 20. So this, once it's available, will probably find its place, not in everybody, but in a specific group of patients who perhaps find it great difficulty getting to the hospital because they live a long way away, or they have other health problems, or they have mobility issues. That group would become immediately very happy to have the port delivery system if it cut down the number of hospital visits that they needed. There are many other treatments that are being considered, including the gene therapy, injecting into the vitreous cavity and underneath the retina, and other intravitreal implants. We simply don't have time to go into all of the studies that are going on, and these, it has to be said, are much further away in terms of being new treatment available to the population very soon. So in summary then, our current treatments are ranibizumab, aflibercept and brolucizumab. We have the brand new faricimab, which does seem to be absolutely excellent, and we're very excited about using that. Here is another demonstration of a choroidal neovascular membrane underneath the eye, just to illustrate the problem of wet macular degeneration again. On the way soon, we hope the port delivery system will be very good in the correct choice of person, and will give them a lot of freedom from the hospital. And I would just want to remind you as well that although we've been through quite a lot, I hope I've described things quite clearly for you. The gold standard treatments are absolutely excellent. The difficulty we have with the gold standard treatments is making sure that every patient gets their treatment exactly on time, because the hospital eye service finds it very hard to keep up with the number of appointments that are needed. Faricimab, which is available now, is likely to be excellent, both for the individual, because a large number of people will need fewer hospital visits, and therefore it will be also good for the population, because there will be more appointments available for other people. And the port delivery system, we think, is on the way, and that, I'm sure, will be very beneficial as well. So that concludes my presentation. I hope you have found that interesting. I thank you very much for your attention, and in the live chat, I'll be very, very happy to answer any questions that anybody has. Thank you very much.